Good morning. I'm Paige Winfield Cunningham, a health policy reporter and author of the Health 202 newsletter here at the Washington Post. And I'm pleased to welcome my guest, Seema Verma, the administrator of the Centers for Medicare and Medicaid Services. And she's here to outline her vision for the Medicaid program, which covers around 70 million Americans and, of course, is a very integral part in America's healthcare future. So let's welcome the administrator. I want to remind our audience in the room and those watching online that you can tweet us your questions using the hashtag #PostLive, and I will pose some of them to the administrator later on in our discussion. Before we get started, I actually wanted to ask you a mom-to-mom question, if that's okay. So now I understand you have two kids, a daughter and a son, and one of them is graduating from high school this week?
Yes, this week. So it's been a big week for all of us at HHS. It's not only drug pricing, but it's graduation for my daughter and for Secretary Azar's. So they both go to the same school, and so we're excited. Big week.
That's great. Well, I have two little ones of my own and one on the way. So here's what I wanted to know. Do you give your kids waivers to get them to help with work around the house?
Everybody's working, and there are no waivers. You just do your job.
Okay. Good to know. All right, so speaking of work requirements, let's start with that because, as you know, it's probably the buzziest topic around Medicaid these days. You so far have approved the community engagement requirements in 4 states, and a half dozen others have applied as well. I want to know, what metrics are you going to use to determine whether these new requirements are a success or a failure?
Okay. Let me talk about community engagement at large. And so these efforts really were born out of some of the changes with the Affordable Care Act. The Medicaid program traditionally has been one that has served the aged, blind, people living with disabilities, pregnant women, and children. And with the Affordable Care Act, we added all of these new able-bodied individuals to the Medicaid program. And so I think states were looking at this saying, we don't want to just give people a card or just health insurance, but we want to try to help the needs of this population. These are individuals that are living at the poverty level, at or near the poverty level. And so what can we do to help them, not just giving health care coverage, but finding a pathway out of poverty, a bridge to independence. And so our efforts were really, as a response to where the states were in terms of wanting to do more for this population. And so what we did earlier this year is we put out guidance for states about how they could structure what we call community engagement. And community engagement isn't necessarily just about work. It could be volunteer work, it could be job search activities, it could be job training. Anything to sort of help that individual seek independence and a pathway out of poverty. So, and then the other thing that we did in the guidance was we also put some guidelines around, what may or may not work. We know that, a community engagement requirement may not apply to all populations. So this is focused on able-bodied individuals, does not apply to, people living with disabilities or pregnant moms or kids, obviously. It's just focused on those groups of individuals. And within that, we also asked states to think about what types of exemptions would be appropriate. So there are some individuals that are facing acute medical conditions, they're medically frail, and community engagement might not be appropriate for them. Or there's individuals that are dealing with substance abuse disorder, opioid addiction, so creating exemptions for those individuals as well. Or they may be living in areas where there may not be jobs available, there may be problems with the economy in that particular area. So to think about how could they create exemptions. So we put these guardrails around the program. The response we've received has been very positive, and when you look at community engagement from a polling perspective, there's a lot of public support for these types of programs. There was also a survey of physicians that was also done that showed high support for this as well. One of the things that we're doing with all of our programs at Medicaid is we're trying to give states as much flexibility as possible, and with that flexibility also comes some accountability. So we're going to have very strong evaluations of these programs. And really the purpose of them is to improve health outcomes. And so as part of the evaluation, and your question, which is how are we going to look at these programs and what types of indicators, we're going to look at health outcomes. the research shows that there is a strong link between people that are working and better health outcomes. So that's one of the things we're going to look at. And we're going to look at individuals who are on the program and how many of them actually participate in the requirement, how many of them actually go on to getting a job and being independent from the program. So there's a lot of different parameters that we're going to be looking at. But it's all centered around improving health outcomes.
There have been some concerns expressed about sort of the difficulty in implementing these kinds of requirements, and that's something I know that the Medicaid plans themselves have expressed to me. Are there ways that you can help them to put these new requirements in place?
So I think anytime you start something new, there's going to be some challenges just understanding the best way to do this. But as I've toured the country and talked to a lot of states, I was actually in Arkansas when their waiver was granted. And we heard some remarkable ideas that they have going on the state level. For example, they had been working on a partnership with some of the nursing homes that said, we need individuals to help be certified nurse assistants, or we need aides. And they actually had a lack of these types of employees, so they were going to run free training programs. And they were kind of building that partnership with the state. They were also working with their community colleges and granting scholarships to some of the individuals that are on Medicaid that were participating in the community engagement requirement. So I think every state's going to approach this differently, but I think it's exciting to see the type of discussion and collaboration on the community level.
I want to ask you about some of the other kinds of Medicaid flexibility states have been requesting, but first let me step back for a minute with a broader question, and that is, how do you want the Medicaid program to look different overall when you eventually leave CMS compared to when you started last year?
I think the Medicaid program, like I said, is a promise to the most vulnerable populations in our society. So I want to make sure that our programs are delivering high quality, accessible health care, that we are improving health outcomes, that we are helping each and every individual that's on the program achieve the best quality of life, and that we are helping each of those individuals attain their highest level of potential. And while doing that, we also want to make sure we're improving health outcomes, and finally making sure that the program is sustainable over the long term. If we look at the Medicaid program, this is the number one or number two budget item in most states, and it's starting to crowd out other priorities for the states. It's education, it's infrastructure, it's job creation. And so there's been a lot of discussion about the Medicaid program and its financing. And just a little bit of history, if we look back at the program, in 1985, states were spending about 10% of their budget on the Medicaid program. And if you fast forward just a few years ago, it's almost a third of their budgets. And so the program originally started as a federal-state partnership where the federal government and the state were contributing towards the costs. But what's happened over time is that states have increased their spending more and more. And with that increased spending came more federal oversight. So more oversight, more regulation. And what we have now in the end is what I'd say is more of a one-size-fits-all approach, where the federal government is basically dictating to states how they run their programs. And obviously that's understandable because of the spending. But I hope to get us to a place where we can agree to what we're going to spend on the program and then provide a new era of flexibility for states. In my personal experience, I worked with the Medicaid program for many years, and before I came to CMS, my job was to work with states, help them design innovative programs, and then work with CMS. And one of the biggest barriers to creating flexible programs, innovative programs to help achieve better health outcomes was, quite frankly, CMS. CMS was the biggest barrier towards delivering innovation. And so I hope to get to a new era where states are driving their programs and they're deciding what's going to work best in their communities because they're closer to the people that they serve, and that we can hold states accountable. So we're going to give them flexibility, but hold them accountable for achieving outcomes, and so we can actually measure what they're doing.
What's your vision, though, for enrollment overall in Medicaid? And I've just been curious about this because, your critics like to say, well, they just want to roll back enrollment, reduce enrollment. Conservatives often would argue, well, that's a good thing because ultimately you want to get people off of these kinds of programs. So, as I mentioned earlier, it covers around 70 million Americans now, which is a lot of people. Where would you like to see that number go?
I think, as I said before, my goals are about delivering high quality care and improving outcomes for the individuals on the program. When I look at the Medicaid program, I think of it almost in terms of two Medicaid programs. There's the program that serves the most fragile, vulnerable populations in our society. These could be people that are living on ventilators or quadriplegics. That's a very different program than looking at the program for the able-bodied individuals. So the Affordable Care Act or Obamacare expanded it to those individuals, to able-bodied individuals. I think it's a different type of program and we need a different response. For those individuals, the goal should be helping them not only to provide health care coverage, but helping them with a pathway out of poverty. It's much easier to just hand a card and say, good luck to you, go get your health care. It's a much harder thing and a higher goal that we have to actually help these individuals live independent lives. And so it is success for us when somebody is able to rise out of poverty and no longer need the program for those able-bodied individuals. If they are able to get a job that provides health insurance and create that independence, I consider that success.
So we've talked about the work requirements, but a couple of other things that states have requested. I think the next thing we're all waiting on is Wisconsin's request for drug testing. How are you evaluating their request and thinking about that?
So when we look at any state's proposal, it's kind of thinking about what is it that they want to achieve. Obviously, our nation is in the middle of an opioid epidemic. The president has asked the Health and Human Services to declare that a public health emergency, so we're very focused on developing strategies to try to address the epidemic. So when we look at some of the things that states want to do, it's understanding where is it that you want to go and what goals do you want to achieve. For a lot of states, what they're looking at is they want to be able to identify individuals that need help. And we've got to figure out what's the best way to identify those individuals and then help link them to the services that are going to be most appropriate, because states are trying to do something about the opioid epidemic. So as we're looking at what's the best way to accomplish that, there's many ways to address that. States could come up with ideas around doing a risk assessment and not only identifying issues around substance abuse or opioid use, but also looking at a comprehensive health assessment to look at all of the types of health issues that a person may be facing.
And then recently you drew a line for how far you're willing to go with flexibility in Medicaid by rejecting Kansas' request for lifetime limits for 3 years, I believe. But do you see any scenarios under which you might approve less strict lifetime limits? I know there are a couple of other states with similar requests. I think Arizona and Utah have asked for a 5-year type of limit. How are you evaluating those requests?
So I think in the case of Kansas, let me just say that's a wonderful state where they've done terrific things with their Medicaid program. They're very innovative. When we put out the guidance around community engagement, what we talked about was making sure that states were aligning with their SNAP and TANF programs, because those programs also have community engagement requirements. And we didn't want individuals to have two sets of requirements. So if they were in SNAP and TANF, we didn't want them to have a different set of guidelines on Medicaid. I think that created a little bit of confusion for states. In the SNAP and TANF program, if an individual is in the program for about 3 years, and after, depending on a certain amount of time, then afterwards, they have to engage in community engagement to retain those benefits. And so and we're comfortable with that approach. What we understand about the Medicaid program is that you're dealing with a fragile population and there are changes in their lives. So, they may be able to go into a community engagement program, get a job, they're independent, but circumstances change, and we always want to make sure that the program serves as a safety net and there's a place for people to go when they need it. What we have approved are what we'd say temporary lapses in coverage. So, an individual may not comply with the requirement around cost sharing and they could potentially lose coverage, but we want to make sure that there's a pathway back into the program, that there's a way for them to come back in if they're compliant with the requirements.
So does that mean pretty much a no from you guys on lifetime limits?
Yeah, we've indicated that we would not approve lifetime limits, and I think we've made that pretty clear to states.
Okay. So let's talk about Medicaid expansion for a minute. It's been 8 years since the ACA was passed, hard to believe sometimes. 19 states, I believe, have not expanded Medicaid, leaving about 2.4 million people in this coverage gap where they can't get Medicaid but then are ineligible for the marketplace subsidies. Do you feel like the remaining states should expand Medicaid? And if they don't, what should be done for these people in the coverage gap?
So a couple of things. I mean, our whole philosophy has been supporting states and where they want to go and what they want to do. We're not trying to push states any which way on this particular issue. If a state comes to us with a state plan amendment request, I mean, under the law, we're required to process that application, and we're going to do so accordingly. At the same time, we're not going to do the types of things that the previous administration did in trying to strong arm and force states into expansion. We saw examples where, they had existing programs where they tried to reduce funding in other areas, trying to be coercive with states and try to push them into expansion. And we're definitely not doing that.
One approach that has been raised is partial Medicaid expansion, like in Utah, and I believe that's something the prior administration had rejected. So Utah wants to cover people up to 100% of federal poverty. Can you give us any insights into your thinking about that type of approach?
So we're continuing to look at that issue. I think we've had a few states, and we're continuing to look at the policy issues around that and what the implications are. If they're doing partial expansion, that means they're coming to the exchanges, and so we're trying to understand all of the implications and the scenarios and what the impact would be. One of the things that we do when we're looking at waivers, and usually the states are coming to us when they have a waiver request, and what that essentially means is they're asking us to waive regulations or waive laws. And they're usually doing that because they want to create an innovative program. So when we look at the parameters around how we approve waivers, we're looking at that in terms of what's the impact going to be on the federal budget. That's a big issue, a big threshold question. We're also looking at what we can waive under the law, what is actually permissible. And then the third area, is it consistent with the objectives of the Medicaid program? So we're continuing to work through those issues.
Let's talk about drug pricing a little bit. It feels like we've been talking a lot about that over the past week. Yesterday, both you and Secretary Azar mentioned you'll be rolling out some updates to the Medicare and Medicaid drug pricing dashboards, and the Health 202 had sort of a sneak peek this morning at that. Can you share some details about what new data you're adding and why you think that will make these more useful?
Sure. So one of the things that we've talked about at the agency from the time we got there is that we want this to be about patients first. And so much of the decision making and policy, we're always thinking about the patients. And so from my perspective, we want to empower patients with the information that they need to make the decisions that are going to work best for them and their families. So we want to empower patients with information about cost, information about quality, and also make sure that they have their health records at their disposal. So you kind of hear us talking about that, and there's a variety of initiatives around those lines. And so we've had a drug pricing dashboard that's been at the agency for a little while, but we've made some updates to this dashboard. And so in the past, what you could gather from this dashboard is you could see essentially what the Medicare program, Medicaid programs had been spending. But we've revised this dashboard, and it's available for the first time today. And this time you'll actually be able to see the prices. You can see for every drug in Medicaid and Medicare what the prices are. And you can also see for the first time the year-over-year price increases. So you'll be able to see whether there's been a double-digit increase or a triple-digit increase, or in some cases a quadruple digit increase. And so all of that information is available as of today.
Who are you aiming at with this dashboard? Who do you want to use it? I mean, just health policy folks mostly, or more of consumers? What do you?
I think it can be everybody, but essentially our philosophy has been around patients first, and we want to make sure that patients have that information. So our goal is to focus on patients, but I think it could be used by a variety of different individuals.
So let's talk a little bit more about the president's drug proposal. There's been a lot of attention paid to the ideas around Medicare, and there's a lot in there. But it also includes a few suggestions about Medicaid, and a lot of this is quite cryptic. So hopefully you can help us kind of understand some of these ideas. But one that I noticed is allowing 5 states to experiment with behaving more like commercial health plans by letting them limit drug formularies and then negotiate prices with manufacturers. Can you talk a little bit about that idea and how promising you see it? I know that Massachusetts has also requested a waiver along these lines.
So I think the issue with drug pricing, there's been a lot of attention obviously on Medicare, but for Medicaid and for states, it's a big issue there as well. And just a little bit of background on how the Medicaid program works with drug pricing. So they're guaranteed a certain level of discounts, and that depends on whether it's a brand or generic. And then that level of discount changes depending on how the manufacturer has priced their product. So if they have increased that price beyond normal inflation, then they're going to be giving additional discounts. So what happened with the Affordable Care Act is they actually put a cap on that. So essentially they put a cap on the penalties that these manufacturers would face. So essentially eliminating any incentive for manufacturers to keep prices lower, and actually the reverse. And what we've seen is over 2,300 drugs, actually the prices have gone up when they made this change in the Affordable Care Act. So that's definitely been an issue for states. But one of the issues that states face is that they are able to get a lot of discounts, and it works really well when there's a number of competitors because they're competing to have better placement on a state's formulary. But I think the issue for states that has been more problematic is that when there are new drugs available, new drugs that don't have competitors. And I think the best example of this when some of the new drugs around hepatitis came out, and we saw some very, very high price tags. And for states, they're not prepared for this. They're on a 1-year or a 2-year budget cycle, and so all of a sudden they have these major costs to pay for, and they're not prepared for it. And so one of the things that we've been talking about with states is, for drugs in this particular category, new high-cost drugs with no competitors, is thinking about modernizing how we pay for medications. So not only in Medicare, but also in Medicaid. Thinking about tools like value-based pricing. And this is something that, we've seen some experimentation going on in the private market and bringing some of that innovation to our Medicare and Medicaid programs. And what this essentially means is thinking about paying for drugs on the basis of the outcomes that it achieves. So maybe paying for the drug over time, depending on whether it's actually delivering results. It could be based on, is this drug able to impact the total cost of care? Is it able to actually lower our spending overall? So we're looking at some ways and working with states. And we'll continue to look at the formulary issue. At this point, I can't comment on any particular state, but that's our overall strategy with states, is kind of thinking about new ways of paying for high-cost drugs.
But you guys could go ahead with this 5-state demonstration. Is that correct? Is that something you're actively pursuing?
That's exactly. We want to make sure that states have flexibility. I think the complicating factor is that right now states do get these guaranteed discounts that I talked about. And they get these guaranteed discounts because they're required to make available every drug that the FDA approves. And so we need to think about, if we're giving them flexibility, are they also able to get these discounts?
Okay. Well, kind of going on, I also did want to ask you, I'm glad you brought up the best price law, because your colleague, FDA Commissioner Gottlieb, has suggested that actually could leave consumers worse off by encouraging drug makers to raise the list prices. Is that something, do you agree with that? Do you think that this best price, these discounts artificially drive list prices higher? And is that something that should be explored for changes?
Sure. I think that the pharmaceutical industry has given us great innovation, not only to the United States, but to the entire world. But innovation really doesn't mean anything if you can't afford your medications. And I think what my colleague Scott is referring to is the whole system of pricing is based on rebates. And it's a convoluted system with the idea of a middleman that's negotiating rebates from the manufacturers. But the manufacturer or the middleman or the PBM is basically negotiating not only with the drug manufacturers, but they're also getting money from plans. And it's just a convoluted system where the middleman is getting money from both sides. And so what we've started to think about is we want to create incentives for manufacturers to lower their list price. And we're, essentially what I think the blueprint talked about is thinking about whether our system should be based on list price instead of these rebates.
What excites you the most in the president's drug proposal? I know that Secretary Azar was asked this question yesterday, and he said that this idea of bringing more Medicare Part B drugs under Part D, to him that was one of the biggest things. But what do you see as like potentially the most significant in helping to reduce drug spending?
Well, first of all, I'm very proud and honored to serve with this team. I think the president's leadership on this issue has been tremendous. As long as I've known him, and every conversation that I've had with him, he always talks about drug pricing. It's a high priority for him. And I think the steps that we're taking and what was outlined in the blueprint is, quite frankly, very historic. No other president has put together a plan like this. There are a lot of different elements in that plan, and they really are structured around a few different areas. The first one is increasing competition. And in the issue that you brought up with the Part B plan and Part D is that a lot of times we don't have competition. You've got some new high-cost drugs, which is why FDA is trying to, increase the time to bring generics and other competitors. So that's one piece, is increasing competition. And we know that within the Medicare program, there are some drugs that are in the Part B program, but the competitor is in Part D. And so we're trying to figure out ways of bringing those programs together, or looking at how we could create some of the things that we've done in Part D and Part B to create an environment of competition. Because when we have competition, that's going to lower prices. And then we're also looking at the area of negotiation. If we create a more competitive environment, we want to give new tools to the PBMs, give them the types of innovative tools that are going on in the private market to negotiate better prices. And then the third area is what we talked about before, is creating incentives for pharmaceutical companies to lower their list prices. And that has to do with looking at the entire rebate system. The whole way the rebate system works is around actually encouraging higher prices, because the higher the list prices, because all of the rebates are based on a percentage of that list price. And so the higher the list price, that means the higher the rebates, there's a higher cut that all the middlemen get. So and then, unfortunately for patients, that means that they're paying more out-of-pocket expenses, because their out-of-pocket expenses are based on the list price. So we've got a comprehensive package. There's so many different things that I think we have in the blueprint, but I'm excited because I think it provides a real opportunity to lower prices for all Americans.
One of the criticisms, though, that I've been hearing a lot over the last couple of days is like, this is a huge list of ideas, and they would sort of tweak things around the edges, but that there's nothing that's going to directly get at the price of drugs. How do you respond to those criticisms?
Well, first of all, this has been a priority from day one. And so we've already done some things to lower list prices. We made some changes in our hospital program, the 340B program, where we knew that hospitals were getting discounts, but they weren't passing those on to our seniors, essentially overcharging them. We already made that change this year. Seniors are going to save $320 million just this year. We also made some changes to the Part D program so that when generics become available, that our seniors have immediate access to that. They don't have to wait a whole year. And that means that they're going to pay lower prices. So we've already made some changes that seniors are starting to feel that are going to lower prices. And I think what we've outlined in a number of different steps, whether it's the changes to Part D, whether it's addressing the incentives, all of those things are going to work together. It's not going to be a one shot and we're done, but we've been working on it over the past year, and we're going to continue to do that.
This has been a great discussion about coverage for the low income, but for a minute I did want to touch on coverage for the 10 million or so Americans that get their coverage through the marketplaces. And of course, I've written a lot, my colleagues have written a lot about your pursuit of short-term and association health plans, which you say would provide people cheaper, leaner insurance options. But do you have any worries that this will end up drawing the healthier consumers out of the marketplaces and essentially leave behind a high-risk pool?
I think when we look at the Affordable Care Act and the impact that it's had, I mean, at this point, we are at triple-digit increases. Prices have gone up over 100% since the Affordable Care Act started. And with these higher prices, what we're seeing is higher deductibles. A lot of folks can't even afford the plans that they have. We have states that only have one choice of health plan, and we've got 50% of our counties that only have one plan. So we're paying more and we're getting less choices. We also, because the costs have gone up so much, there's a lot of individuals that can't afford any coverage. If they're not getting a subsidy, they have no way of getting coverage. And with these states where there's only one insurer, counties where there's one insurer, those prices are going to continue to go up because we've created virtual monopolies. And so what the short-term limited duration plans are about are giving people another choice, giving them an option. Because a lot of times it's a choice between no coverage at all or a type of short-term limited duration plan that potentially could be a lifeline for people that are facing having no coverage at all.
But does that end up with, then are the people in the marketplaces left them with higher premiums than even before?
I think we're assessing the impact. I think some of the actuarial studies show that the impact is not that high. Our concern are for the millions of Americans that have no place because they cannot afford any coverage at all. So unfortunately, we're in a difficult situation because Congress has not addressed the issues with the Affordable Care Act. At the end of the day, we need a comprehensive solution, and this administration has been about trying to address the problems, repeal and replace, because we know that it's just not working.
To kind of end with a broad question here, we saw some pretty significant gains in lowering the uninsured rate in the years right after the ACA's provisions went into effect. And lately we learned that the uninsured rate is creeping back up. In fact, it's back up to 12.2%, which is much higher than most other developed countries. Are you worried this trajectory is going to continue, and how can it be prevented?
Well, I think that it is going to continue because, as I said before, prices are going up with Obamacare. I mean, we've had some states that have had 200% increases. And so while many people are subsidized, you're now creating a new pool of individuals that can't afford coverage. I mean, we've heard horror stories from folks where they were paying a couple $100s a month for their health care coverage, and then after the Affordable Care Act, they're now paying $900 or $1,000, and they've seen the prices go up dramatically, and at some point, people can't afford coverage. And so that's why you're seeing the number of uninsured go up, and I would anticipate that if we do not have changes at the federal level, and Congress needs to make changes, we're going to see the number of uninsured go up. And that's why I think the president has acted. That's why you saw the executive order around short-term limited duration plans and association plans, because that's supposed to give at least an option for individuals that are facing being uninsured because of the costs are so high.
Do you hold out any hope still that Congress is going to act on this? I mean, we all saw sort of the meltdown last year and effort after effort, and it seems quite unlikely now, but how do you view that situation?
I'm always going to remain hopeful because we look at the damage that Obamacare is doing to so many Americans. We're seeing these price hikes, we're seeing lack of choices, and so we're very hopeful. In the meantime, what we've tried to do is focus on what we can do from a regulatory level. We made changes with our payment notice that came out last year to give more flexibility for states so that they can regulate their markets, giving them new tools that we hope will lower prices and create more choices for states.
Can I ask you one last real wonky question? This practice of silver loading, you, I believe, referred to it in the big marketplace rule that you released in April, but is this something that you're going to continue allowing insurers to do next year? As our audience probably knows, this was a practice by insurers, which basically meant that consumers could get more generous subsidies in the marketplaces because the silver plan rates were increased. But can you give us any insight into that?
We continue to look at this. I mean, I think that generally with the Affordable Care Act, I mean, it seems like any move that you make, it's a difficult issue because the underlying structure of Obamacare just isn't working. And so you make one move in one area, try to help one group, and it's going to have an impact. So we're continuing to look at the impact of silver loading, as well as a lot of different things that are going on in the market.
Okay. And any final thoughts on kind of what you would like to look back on as sort of your biggest accomplishment when you end up leaving CMS in the future?
I think that's the problem. I have a long list of things because I think our healthcare system is moving in a concerning direction. From a broad perspective, we have a lot of exciting technology and innovation and new treatments and therapies, and we want to make sure that we're delivering high-quality health care to our beneficiaries. But we also understand that the large role that CMS and the large role we play in the footprint that we have in the entire industry. Recently, our actuaries released a report that talked about where the cost of health care is going, and that by 2026, it'll be $1 in every $5. And that's something that keeps me up at night. We really need to do something about bending the cost curve while at the same time delivering on, giving people innovative therapies. And so building some efficiencies in the system. We also want to work into a new era of what I'd say patient empowerment. We've had so much discussion over the years about, how to lower prices. And for everything that we've done, we've increased regulation, we've regulated everybody. Thousands of pages of regulations. We have a new healthcare law that's was supposed to provide coverage to all these individuals, but it didn't do anything about the underlying drivers of healthcare costs. And so after all of that, we haven't done anything to lower the cost of healthcare or the rate of growth. And I think that's a goal not only for CMS, but hopefully for the entire nation, because we're on an unsustainable trajectory.
Well, unfortunately, that's all the time we have for today. I'd like to thank Administrator Verma for joining us.
Thank you.
And if you'd like to watch the full interviews and highlights from today's program or from any past Post Live programs, head over to WashingtonPostLive.com. And thanks to everyone for being here and for tuning in.